ride was longer than this, but I have to say it was well worth it, and I've really enjoyed being here, and I've learned a lot, and I've enjoyed meeting many of you and speaking to many of you, and the leadership and wisdom that Jim Ogilvie has imparted on this meeting. We had a great time last night, had terrific political discussions at the table, and then went for a nice boat ride, and saw the Prime Minister's residence, which is really quite nice. We should get to a party there next time. And but I do warn you that one of our esteemed colleagues is a descendant of a 4'11" horse thief who was one of the original occupants of the penal colony here. So keep your horses in the barn. So, all right. So I've got a fair number of pictures here, which will keep you awake. So Jim Ogilvie spoke about the natural history. I won't spend too much time, but it is variable for hemivertebrae and is impacted by the location of the anomaly, its growth potential based on segmentation, and the health, I guess, of the growth plate, whether the hemi is incarcerated, and whether it's associated with a contralateral bar. The classification is known to you all. And for kyphosis, there's a type 1 failure of formation and type 2 failure of segmentation defect. So the treatment options, I think, were outlined very nicely, but certainly observation is the mainstay, and bracing maybe does have a role. And we saw a patient yesterday, the patient with the feeding tube, who was being braced. And I think it has an application for long, flexible, and progressive curves in particular, and love to know what your experience has been with bracing. In terms of surgery, we'd reserve this for progressive curvature and those associated with decompensation, a lumbosacral hemivertebra, for example, and for failure of segmentation anomalies, the type 1 kyphotic problems may be associated with dislocations or neurological deficits, so these have to be watched very closely. And type 2s, if they do show progression, we address those as well. And contralateral bars, I think, should not necessarily be operated on the day you see them, but we should observe them very closely and anticipate that progression may occur. This is a typical lumbosacral hemivertebra here with an oblique takeoff of the lumbosacral spine and coronal offset. So what are our surgical options? Again, Jim outlined that very nicely, and we heard extensively about hemiepiphysiodesis and its potential, AP fusion in situ, and then finally the hemivertebrae excision, which can be done through a combined approach or posterior alone, either through an eggshell procedure, including the fusion of the end plates above and below, or through a resection of the hemivertebra itself, and vertebral column resections for non-segmented hemivertebra and complex rigid and angular deformities. The extraspinal approaches were also discussed. So I think for hemivertebrae excision, a complete correction is desired. Optimally, we achieve a short segment fusion, which allows the maintenance of growth, preservation of motion segments. It allows us to restore balance in those that have the lumbosacral takeoff. And again, I think the posterior approach in my hands is the way to go, but both approaches are valid. And the history is outlined here. McLennan first reported on a posterior excision with very little correction in 1922, and the various authors over the years have reported this technique, but the early reports were characterized by high rates of pseudarthrosis and lack of correction and kyphosis even. Leatherman emphasized the importance of including the entire index curve and a shortening of the convexity rather than a lengthening its inherent neurological risks, as Jim Ogilvie pointed out. And then later, Leatherman and Dixon spoke about the use of posterior instrumentation. And as we've heard, Ruff and Harms popularized or have published on at least the posterior technique, and many of us are applying that in our practices. So the indications for hemivertebrae excision are outlined here. coronal or sagittal decompensation, the classical indication being an S1 or L5 hemi, progressive curvature, and the segmented or semi-segmented hemivertebrae are present themselves very nicely to this technique, and I think early addressing of the deformities allows for a very focal approach to this problem. Here's a lumbosacral hemivertebra with a coronal offset. And the preoperative evaluation, I think we can get subtle information about subtle neurological involvement, asking patients about, or their families about limp, pain, bedwetting, and which may indicate tethering or mass-occupying teratoma or lipoma, or diastomatomyelia. One can find subtle neurological findings looking at the calf circumference, for example, and sometimes patients have calf asymmetry, and that may be the only indication that there may be some intraspinal pathology, cavus foot, for example, and I've seen that in a patient myself. Radiographs we've discussed. Screening MRI is important. Belmont published in 2004 indicating that even with a simple isolated hemivertebra, the prevalence of intraspinal anomalies is 28%. I think in some cases for these relatively straightforward hemivertebrae, the coronal MRI gives you the information. This is not actually the best study, and I do agree with Jim, you have to ask for it because they don't always provide it to you. But CT scans for most of the patients is appropriate, including the pretty pictures that the 3D scans offer. I find them not to be all that helpful because of the signal averaging, and I can't make much out of it. So I think it's nice for the presentations, though. And we want to look for other system abnormalities, and I think you can avoid maybe the ultrasound by just looking at the coronal MRI. You can see the patient has 2 kidneys and their location, et cetera, et cetera. So it was a paper at the SRS a few years ago talking about that. So this patient came to me. She's an early onset, under 5 years old, with this very severe and progressive curve. I think she was 3 at the time. And the CT scan that we did picked out this semi-segmented hemivertebra that we really didn't appreciate on the plain radiograph. And obviously, some pathologies are fairly obvious. Here's an illustration of the AP technique in which the hemivertebra is completely excised, the disc above and below, down to the canal, and you take out at least the anterior portion of the pedicle through this anterior approach, and then flip the patient over and do this, the corresponding hemilamina pedicle, rib head, and lateral aspect of the rib. So, Jim, have you done any of these simultaneous with simultaneous front back, or has anybody in the room done that?
I've done several of them front and back, and it became obvious to me that I probably could do so on that, but it's sort of an evolutionary process.
But did you do them, with the patient on their side,
Yes.
doing both together at the same time? Yeah. Does that still? All from the posterior approach now. So, and I agree, sometimes what you see in the back doesn't correspond to the front. And in Ghana, when we go there and do surgeries with Dr. Boachi, we don't have the benefit of x-rays. So you go in there and you look at the apex, and we do it all from a posterior approach, and said, okay, I'm going to take this out. And often when we do get a post-operative x-ray, it's not exactly corresponding with what our plan was, but patient's balanced. So we took out what we had to based on what we see. So, and I think that's been a great experience for me. I've learned a lot through that. Here's a 16 or 17-year-old young lady with a semi-segmented hemivertebra and a progressive lumbar curvature. And we tried to do this with a relatively short segment fusion. We took a disc above and below. Here's the hemi in here, so we took that out as well, down to the canal through a relatively small and cosmetically acceptable anterior approach. And although she's not perfect, she was skeletally mature, and she's really stood the test of time. I had follow-up on her out to about 5 years, and she was doing well throughout that time span. And here she is several years after surgery.